Thank you, Audrey. This meeting is being recorded. The recording will be posted on the Cost Board's webpage shortly after the viewing and may also be streamed on TBW Live and archiving it for additional viewing opportunities. As always, we have a full agenda today with some new and returning topics. It can be found in the first tab of the meeting materials. Eileen Cody, Chair of the Stakeholder Advisory Committee, will now call the meeting to order.
Thanks, Ross, and welcome everyone to the May 22nd meeting of the Joint Data Issues and the Stakeholder Advisory Committee. I'll call that meeting to order. I want to give a warm welcome to everyone and thank you for participating with us. The board wants to make sure that you realize that we do appreciate you and that thank you for your help in trying to move the state of Washington towards our goal of making healthcare more affordable. Today's agenda is to approve the past meeting minutes, to take public comment. We're going to have a presentation and some discussion about the ASI strategy analysis and feedback, and a presentation and discussion about hospital expenditures with a legislative update. So I'll hand it over to Ross now for roll call.
Thank you, Eileen. I will run through roll call now, starting first with the Data Issues Advisory Committee, and I'll be going alphabetical. When I call your name, if you could say present, it would be greatly appreciated. Krista Abel.
Krista's present.
Thank you, Krista. Dr. Nzapike.
Present.
Thank you. Megan Atkinson. Megan Atkinson. Amanda Avalos.
Hello.
Thank you, Amanda. Jonathan Bennett. Jonathan Bennett. I'll mark Jonathan is absent. Bruce Brazer.
Yep, present.
Thank you, Bruce. Jason Brown. Jason Brown. I'll mark not present. David DiGiuseppe. David DiGiuseppe. I'll mark David is not present. Chandra Hicks.
I'm here.
Thank you, Chandra. Leah Hole Marshall.
Present.
Thank you, Leah. We're expecting David Mancuso to be absent today, but David, are you with us today? Okay. And we're also expecting Anna Morales to be absent today. Anna, are you here today? Okay. So Anna and David Mancuso will be noted absent. Hunter Plummer.
Present.
Thank you, Hunter. Mark Pringler. Mark Prigler. We noted absent. Russ Shust.
Present.
Thank you, Russ. Mandy
This is
Starr.
Mark.
I'm
Sorry,
here.
Thank you, Mandy. And apologies.
This is Mark Pregler. I'm sorry, it was double muted.
Oh, okay. My apologies. I moved too quickly. Thank you, Mark. Julie Sylvester. Julie.
I'm here. I'm here.
Okay. Thank you, Julie. Excellent. That is 1, 2, 3, 4, 5, 6, 8, 9, 10, 11. That's 11 members of the Data Issues Committee. That constitutes a quorum. Thank you. I will now run through the Stakeholder Committee through alphabetical order as well. Apologies. Thank you for your patience as we go through this. Emily Bryce.
Can you hear me? Present.
Yes. Thank you, Emily. Patrick Connor. Patrick Connor. I'll mark Patrick absent. Bob Crittenden.
Here.
Thank you, Bob. Paul Fishman. Paul Fishman. I'll mark Paul as absent. Jamie Fowler. Jamie Fowler. Mark Jamie is absent. Justin Gill. Justin Gill. Mark Justin is absent. Adrian Jones.
I'm here.
Thank you, Adrian. Jody Joyce.
Yes, I'm here. Good afternoon.
Thank you, Jody. Good afternoon. Expecting Louise Kaplan to be absent today, but just to check, Louise Kaplan, are you present today? Okay. Mark Louise absent. Stacy Kessel. Stacy Kessel. Mark Stacy is absent. Eric Lewis.
Present.
Thank you, Eric. Not expecting Vicky Lowe, but we'll ask. Vicky, are you present today? Okay, we'll mark Vicky absent. Desalia Martinez Kohler.
Present.
Thank you. Sulan Molnarek, and I
Present.
apologize. Thank you if I misspelled or mispronounced that. Michelle Ratella. Michelle Ratella. Mark is absent. Paul Schultz.
Afternoon.
Thank you, Paul. Jeb Shepard.
Present.
Thank you, Jeb. Dorothy Teeter.
I'm here.
Thank you, Dorothy. Wes Waters.
Hi, Wes Waters is on, but I can't get promoted as a panelist if you can hear me.
I can hear you, and Audrey will be able to promote you to a panelist. It appears you're already a panelist. Yes. So you should be able to turn on your camera, Paul, if you would like. And if you have any more assistance, you can connect with Audrey in the chat. She can assist you.
Yeah, this is Wes Waters. I am on and now have been accepted as a panelist, so I should be good to go. Thank you.
Thank you. Excellent. Thank you. We have a quorum as well with our stakeholders. Thank you for your patience as well as I go through the list of names. And I will send it back to Eileen.
All right, thanks. And we're going to move on to tab 2, which is the meeting, our last March meeting summary. And let's see, it's also on the screen. And as for you to notice, I can't even talk today. A note, recording of the prior meetings are posted on the webpage for reference or review. And so saying that, do we have any comments or concerns with the meetings minutes as presented? Do I have a motion to approve the minutes?
So moved.
Second?
Second.
Thank you. All those in favor say yes.
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 And opposed? Okay, then our meeting minutes are approved. I'll hand it over to Bianca.
Okay, hopefully you can hear me. I'm just having a little bit of problems with my audio. But I'll assume that you can all hear me okay?
We can hear you, Bianca.
Okay.
A little staticky, but can
Okay.
hear you pretty well.
Okay, thank you so much. Well, I apologize for that. So let's go ahead and turn to tab 3. Tab 3 is public comments. So as we prepare to take public comments, so we have written public comments that we received since our last meeting, which can be found under the 3rd tab of the board materials. The advisory committee welcomes and encourages public comment and appreciate all feedback received. Public comment is essential as it provides an opportunity for the public to have their voice heard at regular meetings when the advisory committees are making recommendations to the cost board. Public comment can be provided orally at the meeting or in written form. The advisory committees review and consider all public comment received. The advisory committees will not respond to the public comments during the meeting. If the advisory committees deem appropriate, a response will be provided in writing or at the next public meeting. So if you would like to provide public comment, please raise your hand, then I will call on you after we hear from individuals who have first signed up. When you are called upon, please state your name and affiliation, if any, before speaking. And please accept the invitation to become a panelist in order to turn on your camera and provide public comments. You're also welcome to provide comments in writing via email at any time. So let's see. We have commenters. So it looks like we have Patrick Connor, stakeholder on the stake. Oh, I see that we have just someone saying that they're present here from the committee. Do we have any public comment from
See
anyone?
any hands raised right now?
No has
And
raised,
we
and
did
we
not
also,
receive any public. Okay, we didn't have any in advance.
correct. Thank you, Bianca.
Anyone raising their hand?
Not yet.
None at this time.
Okay. Do we want to give it another minute or so, or should we go ahead?
Sure. I think we can give it maybe 30 more seconds in case anyone wants to provide any comments. And I do welcome folks. If anyone is ever interested in participating in person at these meetings, we do hold them hybrid. We have a location at the HCA offices here in Olympia. Today, I'm the only person here and would love if anyone ever wanted to come join, but appreciate folks being online as well. But since we had a little time, I thought I would invite folks to come. Would love to get to meet you in person.
And they can use the HCA cost board email address to provide those comments, right?
Absolutely.
In the
Yes.
future.
Thank you. Yes. In that email, one of our staff members will drop that in the chat just so folks have that handy. Thank you, Bianca.
No problem. Okay, I'm not seeing any public comments, so I think we'll go ahead and move on to perhaps tab 4. So let's go ahead, go to tab 4. We have Harrison Fontaine, the Senior Health Policy Analyst at HCA, who will present an overview of HCA's report and data streams, key findings and takeaways with an emphasis on how the Analytics Support Initiative complements other analytic work. The ASI is a 2-year project. It was supported by the Peterson Center and Gates Ventures, and it's ending here in August. Harrison will then hand the presentation over to Joe Dielman from the Institute for Health Metrics and Evaluation. Both Harrison and Joe's presentations can be found in tab 4 of the meeting packet. So Harrison, please go ahead.
Thank you, Bianca. With that good introduction, I'll just sort of jump into it. The purpose of this brief sort of intro presentation is to set the stage for the really interesting and sort of fresh off the presses data that Joe will be showing shortly here, and also to level set a little bit. I know we have a varied audience here and some new folks, some seasoned folks. So trying to put in context the information that you will see into the broader context of the analytic work that we're doing for the board. So you can see here in this slide a highlighted version of 3 of the main reports that supports the board's work in terms of determining policy direction. These are the performance against the benchmark report, which is an assessment of cost growth against a target benchmark, essentially at several different levels. A main cost driver analysis. There are a few different cost driver analyses, but there is one that's specifically focused on those cost drivers. And then lastly, the Analytics Support Initiative is an effort led again by IHME, the Institute for Health Metrics and Evaluation, and that is what we'll be sort of expanding on today. Next slide, please. So as we think about these data reports, I think it might be helpful just for a second to take a step back and think about data streams. And by that, I really mean sort of considering first the data sources that form the foundation for these reports. And it just so happens, it doesn't necessarily need to be this way, that currently each of the reports is based on its own data source, really. And for the data call, for example, for the performance against the benchmark, for example, we have that being built off of the data call. In the case of the main cost driver analysis, that's built off of the all payers claims database. And then in terms of ASI, that is built off of a database called DEX, the Disease Expenditure Database. And so we have these varied databases that inform both our reports and interactive data visualizations, and all of that sort of funnels up to support the board's policy recommendations. The interactive visualizations, although interesting, are going to be sort of separate from this presentation and out of scope today. So we'll focus on those reports. I'll go to the next slide, please. All right. So here you see an overview of really what those data sources are and just trying to lay out sort of the groundwork of how they compare to each other. The data call, which is essentially aggregated information from carriers and providers, provides really high-level summarized information in the data source and gives us a high-level view of what's going on within the state of Washington. The all-payer claims database, on the other hand, is more granular. It provides claims-level data that allows us to do deeper dives. And then there's DEX. DEX is an interesting sort of addition to these first two, and really what it does is provides estimates that are adjusted to be representative for the entire state of Washington. And these estimates are granular. They do allow us to do deeper dives into what we're seeing. It's also worth noting that the recency of some of these databases is a little bit different. And like I said, today we'll be focusing on that information that is coming from the DEX and ASI project. Next slide, please. So just very briefly pulling out a few key differences here. Really, this slide's mostly for reference, but I'd like to focus on the differences that we see between the data call and APCD and DEX. For example, we see non-claims and other related costs, essentially net cost of private health insurance, being reported for the data call. And so that's in that database, but that's not reflected in the information we see in the APCD or DEX. And that's important when we consider policy implications of this data. On the other hand, when we are interested in considering price and intensity, utilization, conditions, doing those sort of deeper dive analyses, that's when we turn to the APCD and DEX to do those deeper dives or sort of more nitty-gritty analyses. Also to mention here, again, the data that DEX provides are estimates of the true values after those adjustments have been made. Let's go to the next slide, please. So I'll touch on a few key takeaways from these data reports. First, the ones that are sort of in the background today, the performance against the benchmark report. That comes, as I've mentioned before, from the data call, and it really allows us to assess performance against this target at the level of the state, carriers, and large provider organizations. We also use it to conduct a sort of a rudimentary cost driver analysis, looking at service level data in that cost driver analysis. But we use our main cost driver analysis, which is currently conducted by OnPoint, to do these deeper dives, where we are looking at service category level cost drivers and considering within that the different contributions of both utilization and price. So that brings us to ASI in the next slide. So the ASI, the Analytic Support Initiative, has a similar focus to the cost driver analysis, but it is different and complementary in a few different ways. So it not only provides service category level data, but also condition level cost driver analysis. It considers not only utilization and price, but also population characteristics, something that's interesting, an interesting addition to the analytic portfolio. And then for today's presentation, a few things to note is that it allows us to do regional analyses and look at these regional patterns in terms of things like utilization. And then it also allows us to look at very specific conditions, the trends we see in those conditions, and we can imagine linking those things back to expenditures and potentially avoidable expenditures would be one example that we'll be touching on later. Next slide, please. Okay, so again, this slide is mostly for reference, but I would like to draw out one thing, which is an important difference when we talk about service categories between these different analyses. So by service categories, I mean things like inpatient, outpatient, pharmacy spend. And when we consider the Analytic Support Initiative, the way those service categories are chunked is a little bit different than we see in the cost driver analysis and the performance against the benchmark. One key difference there is this ambulatory services category, which is sort of a larger group that includes outpatient hospital, and several other things, including primary care. We can go to the next slide. So, key findings from some of these reports I think would be useful to hang on to as we go into the ASI findings, updated ASI findings. One is that within our performance against the benchmark, which allows us to, again, evaluate performance against the benchmark and monitor overall trends within the state, the hospital outpatient, retail pharmacy, and non-claims spending as being some of the key drivers that are identified in that analysis. This lines up fairly well with the main cost driver analysis in terms of which categories are pulled out there. And another thing to pull out from the main cost driver analysis, sort of a top line conclusion, is that especially in the commercial market, increases in price in terms of cost per service were largely driven by spending trends across all categories. And let's go to this next slide. All right. In terms of how the ASI fits into this picture and sort of the key value adds of the project for the agency, especially as we're considering sort of the analytic portfolio going forward and the value add as we near the end of this project. The Analytic Support Initiative has provided comprehensive and granular analysis that allows us to really inform where we are and give us a deeper dive and a deeper view into the data that informs policy levers. In addition, really this fantastic analytic capacity that's paralleled our internal capacity building efforts has allowed us to make comparisons and look at patterns that we wouldn't otherwise as we are standing up our internal analytic capacity. And lastly, that DEX data source that I mentioned earlier does sort of fill in the holes where we have missing bits in our other data sources. When we can consider key findings of the last ASI report. So there was an ASI report that was in the legislative report last year. From that, we can note a few things. Importantly today, again, we see increases in price being the primary driver of spending across categories, and also demographic shifts, which is one really key feature of this project. We saw that those demographic shifts primarily affected Medicare spending, with other payers, Medicaid and commercial, being less influenced by those shifts in demographics. And then lastly, spending on behavioral health disorders increased at a very fast clip. This is consistent with our other cost driver analysis, and this clip was faster than the rate for other health conditions. This is something that we'll be providing a little bit more detail on in Joe's talk. With that, we'll go to the next slide for some discussion questions to consider. Rather than open up these discussion questions now, I think it would be best to save them for after Joe's presentation, but I do want you to be sort of thinking about these in the back of your mind as we go through that body of work that we'll be looking at in just a second, and really thinking about two different types of questions. One is, do you have any specific feedback for the direction of the cost board's analytic portfolio? Are there other analyses that you might think would complement the work that we're doing and have sort of outlined here and in the next talk? And then also, is there things that you're seeing in your work that might inform how we address the trends that we are talking about today, and especially in this upcoming presentation? With that, I'll pause for a second before handing it over to Joe, who will dive into this IHME analysis of essentially utilization trends for hospital services, as well as a deeper dive into a few select conditions. Great. Okay, with that, Joe, are you online, and would you like to dive into your slides?
Yeah, thanks so much. Thanks, Harrison. Can you hear me okay?
I can hear you great. Go ahead.
Great, thanks. Thanks, everybody. It's always nice to be able to present to this joint committee. I've done this a few times now and always appreciated the feedback. I'm going to present today on some of the content that Harrison was kind of alluding to. but I want to highlight that, we have time for discussion built in at the end. But if there is questions as I go through, a couple of the slides are a little more technical than others. Don't hesitate to jump in with interruptions. Just take yourself off mute if you're on one of the committees and have a question or something isn't clear, please interrupt. So next slide. So Harrison kind of mentioned this, but this has been a 2-year project. It's been really a joy to collaborate with both the Cost Board and the HCA, as well as various committees throughout this project. We're wrapping up. We're nearly done. One of the big outputs, as Harrison mentioned, was one of the reports that we supplied at the end of the 2024 calendar year. Our last few months of this project are focused on what we're kind of calling our secondary analysis, and it's secondary to the findings that were published in that report. Next slide. And so that secondary analysis is really all about trying to understand utilization in the state of Washington. And so we have a couple of different kind of key questions that were crafted with consultation with the Healthcare Authority, with the Cost Board, and together kind of decided this was the direction that we'd go in. So really focusing on utilization, thinking about the distinction between using services that are outpatient services versus hospital admissions. And so really this analysis is kind of trying to compare those two things. We had 2 different approaches that we used for this analysis. The first is aggregate. And so we're just looking by county at the total amount of visits, outpatient visits, or hospital admissions or emergency department visits. Again, per capita, we've age and sex standardized to make comparisons fairer, but ultimately it's across all health conditions and looking at really differences in utilization rates. The second part of the analysis says, well, can we dive in and look at some specific health conditions? And I'll talk about the process that we use to assess which health conditions to look at when I get to that part of the presentation. But we'll start with this kind of aggregate analysis. So next slide. Next slide. Great. So this is the first slide. This is a figure that's kind of showing the relationship between outpatient utilization. So I'll use, and you'll see in the slides, ambulatory care. In our world, ambulatory care is essentially all outpatient care. It could be outpatient care that's happening at a hospital, but doesn't include an admission. It can be at a primary care clinic, an ambulatory surgical center, really anything that does not involve an admission, isn't an emergency department, isn't a dental clinic, isn't home health, but is at an actual facility, kind of counts as ambulatory care. And what you see in this figure is the counties in the state of Washington ranked on the bottom, left to right, as having the highest utilization rates of ambulatory care, and going down to the counties with the lowest amount of utilization of ambulatory care. And the point of this figure was really to assess if there is a relationship when we look across counties that suggests some sort of trade-off between emergency department and ambulatory care. And so what we really wanted to see is if we rank order the counties in this order, going from highest utilization rate to the lowest utilization rate, do we see a pattern if we rank the counties in the same order for emergency department care? And what you see with this black line is that it's kind of flat. There's not a clear pattern. And so this is kind of one of our first takeaways, is that we didn't see at the aggregate level any sort of trade-off between ambulatory care and emergency department care. Next slide. So this next slide is set up the exact same way. Ambulatory care utilization is on the bottom. The counties are in the exact same order as in the last slide. So the purple part of this figure is the same in the last figure and this figure. But now on top, instead of having emergency department utilization, we have inpatient utilization. And again, the goal here is to just see, is there a relationship as we look at the counties, rank order from highest ambulatory utilization to lowest, do we see some sort of relationship with inpatient utilization? And again, we don't really see a pattern. The black line is relatively flat. The counties are kind of bouncing all over. And it suggests at a very aggregate level that there is not a very clear trade-off between outpatient care and hospital inpatient admissions. Next slide. So the next part of our analysis, continuing to focus on this aggregated level, said, well, if there is not, if there's not a clear trade-off that lower inpatient utilization or lower emergency department utilization where ambulatory care was higher, do we see any relationships with any of the covariates? So if we look at the characteristics of the counties themselves, do we see any relationships? And so this here figure, both pair of figures, has on the x-axis the counties ranked from wealthiest on the far left to lowest income on the far right. And here we do start to see a relationship. We see that the figure on the left, which is inpatient care, shows that for the wealthiest counties, there is less reliance on inpatient care and more reliance on ambulatory care. So the y-axis here is the relationship between ambulatory care and inpatient care. Or another way to think of it is how many outpatient visits do you have per inpatient admission? And so the counties way on the left, the wealthiest counties in this state, have about 120 outpatient visits per hospital admission. So quite a few outpatient visits relative to one hospital admission. If you go to the lower income counties, we see that goes down to about 90 outpatient visits per inpatient admission. And so the takeaway here is that while we didn't see a very clear trade-off between inpatient and outpatient care at the aggregate level, we do see that the wealthier counties are relying more on outpatient care and less on inpatient care. And the panel on the right essentially does the same analysis, but instead is looking at emergency department care visits relative to outpatient visits. And so the y-axis there is how many outpatient visits do you have per emergency department visits. And so the wealthier counties tend to have about 28 outpatient visits per emergency department visit, whereas the lower income counties tend to have closer to 23 outpatient visits per emergency department visit. So again, we see this kind of relationship, again, at the very aggregate level, that the wealthier counties are relying more on outpatient visits and less on emergency department visits and inpatient admissions.
So Joe, did you also do this? Is it all just based on the county income? Can you divide it out by coverage, whether it's Medicaid versus Medicare versus commercial?
Yeah, great question, Eileen. Thanks for asking. So we did. I don't have slides on this, but we did this in consultation with the HCA and saw the same relationship. And so this kind of same, regardless of which of the payers, just for background for everybody, our analysis really focuses on 4 different groups of payers. We have Medicare, Medicaid, private insurance, and then out-of-pocket, which is inclusive of people spending on deductibles and copays, as well as the uninsured. So we really focused on Medicare, Medicaid, and private insurance, because that last group is a little bit of a mix. And we saw the same relationship, that the wealthier counties were utilizing outpatient care more, and the lower income counties were utilizing hospital admissions and emergency department care more. And that was
but I guess my question is,
yeah,
and it's sort of similar to what Jody's asking about. She has in the chat about the PCP supply. Mike, is it like Medicaid has a harder time seeing an outpatient visit or just go to the ED compared to commercial insurance?
Exactly. So when we just take and look at just the Medicaid population, we
Yeah.
still see this relationship. And if we look at just the private insurance, we see this relationship. And if we look at just the
Okay.
Medicare, we still see the same relationship. Yeah. Yeah, great question. Jody, you had a comment in the chat. I'm trying to pull it up.
So my question is income a proxy, is wealth a proxy for PCP supply? So
Yeah,
could this be related to it's harder to recruit and retain in a lower income county, and so there's less supply, and it's affecting the dynamics of the need to use ED in hospital differently?
Yeah. Thanks. So let me go to the next slide and then try to come back to your question, Jody. So the next slide here is the exact same, but now on the x-axis, before we had the wealthiest counties on the left and the lowest income on the right. Now we have the most urban counties on the left and the most rural on the right. And you see the same relationship. So here now we're seeing the urban counties rely more on outpatient admissions. The rural counties rely more on either outpatient and emergency department care, or hospital admissions. And that, again, this kind of downward sloping line suggests as a county becomes more rural, it's essentially less dependent on primary care, more dependent on inpatient admissions and emergency department care. And so I think your question is a great one that we should be able to assess. We do have estimates at the county level of, it's hard to get specifically to PCP, but we can do, there's different ways MD can be broken up, but we can't quite get to like a primary care physician, but we can look at MDs per capita for sure. And I think we can get more granular than that on kind of specific sort of MD as well. So that's something that we could come back to. That's a great question. Jonathan?
Yeah, you may have mentioned this, but I was just curious, is this based on the patient zip code or where the care is being delivered?
Yeah, great question. Thanks. Sorry, I don't think I mentioned that today. This is about the residence of the patient. So it's where they live and not where they're seeking care. Yeah. Hunter?
Yeah, I was curious, since this is a ratio of kind of ambulatory to inpatient, I was wondering if you had looked into any, kind of drilled down if there was any kind of more dominating factor with that. Like, for example, like you have the same, ambulatory kind of rate per capita, but perhaps, one side had a higher inpatient per capita, and that was driving kind of the factor.
Yeah, so we did. Thanks. I was remaking this slide, and it was too late to include in this presentation, but we essentially just did it with the utilization rates instead of the ratio, because sometimes ratios are unnecessarily complicated and you don't really know if the change is in the numerator or the denominator. And so you see these same relationships. So kind of the way that I'm voicing over about more reliance on ambulatory care for the wealthier urban counties and more on ED and inpatient admissions on the less wealthy rural communities is really exactly what we're seeing. It's not the ratio isn't kind of distorting it in any way. It really is that the utilization patterns are as I'm saying they are. So yeah, thanks for asking.
Yeah, thank you.
And Joe, we had one more question from Patrick in the chat.
Great. It says, was the per capita availability of outpatient facilities taken into consideration? So I think that's a great question, Patrick. Just like MDs per capita, we can look at trying to think what variables we have at the county level. We would have hospital inpatient beds per capita, so we could see how that's correlated with this. That's going to be, hospitals are going to be a lot, organized around more urban areas. As far as outpatient clinics per capita, I'm not sure what variable we have on that, but I think we can get at least at the MDs per capita and investigate, I think, what you're getting at. So great.
Okay, yeah, it seems to me that if there's only, say, one outpatient surgical provider in a county of 100,000 people compared to 10 of those, in another county. It's kind of hard to make sense of where that might fall on the graph and how, from a cost perspective, you might be able to really address that.
Yeah. No, that's really important. I mean, I think this hints in a non-causal way at, an access issue, but it doesn't explain why there's an access issue, right? It doesn't say, it could be access that is supply driven, meaning there's not primary care physicians, there's not primary care facilities. It could also be that the demand isn't there, that people aren't actively seeking it. Could also be that insurance coverage isn't there. There's lots of things that can influence access to care. And I think trying to drill in on those a little bit more would be great. I think that's great feedback from the group. So
Thank you.
We can certainly do so. So why don't we go go ahead, Eric, and then we'll go to the next slide after that. Eric, go ahead.
Oh, just one comment about rural healthcare. I worked in rural healthcare for over 20 years.
Yeah.
And I think the big thing about rural healthcare is the population is older.
Yeah.
And the population is poorer than urban areas and has less education. And lifestyle and age can often drive this, and there are far fewer outpatient services available in rural areas. Sometimes the hospital may be the ED may be the only option, where in urban areas you have urgent care and more primary care access.
Absolutely, yeah. So we are adjusting for age and sex of the population here. So we've standardized by age and sex.
Okay.
But you're spot on, of course, that the populations are distinct. We're here looking at urban versus rural, and we're looking on a wealth continuum. But there are other differences between the urban counties and the more rural counties within the state. And again, back to my point that access is a pretty complicated thing. And in some ways, it kind of sets me up for the next slide. If you want to click to the next slide, I'll kind of introduce go back one slide, sorry, just to keep it simple on this slide. So I want to motivate our next analysis, as I mentioned before when I was talking about our approach, was to look at specific health conditions. And some of that had to do with Eric's point, is that the underlying health of wealthy urban versus rural poor communities is different. And so when you're looking at an aggregate analysis, you can't, it's hard to adjust for those things. That ratio that we were looking at was kind of an attempt to adjust for that, because it was looking at the ratio of outpatient to emergency department, or the outpatient to inpatient care. So that was a kind of our attempt in the aggregate level. But as soon as you're willing to dive into health condition specific analyses, you can condition on the disease prevalence. And so now if we go to the next slide, we wanted to identify a set of health conditions that, to continue this analysis, specifically looking at ambulatory care versus inpatient and emergency department care, we wanted to identify health conditions that generally can be treated in an outpatient setting. And so this gray box on the left, CMS and AHRQ each have their own kind of lists that are of health conditions that by and large can be treated outpatient. And so CMS calls this their potentially avoidable hospitalizations list. These are health conditions that you should be able to avoid a hospitalization. Doesn't mean it's always avoidable. This is the potentially is an important word here. But in general, it is a hospital admission that maybe one should look at and ask, was that absolutely necessary, or could it have been avoided? AHRQ has a similar list where it looks at health conditions that it believes are ambulatory care sensitive. So these are really similar lists. And so we started with those two lists. And then we said, well, from those lists, what health conditions on those lists do we also have all the necessary input data for? And then the next thing we did is, well, of those that we have the data for, and that are, according to CMS or ARC, are considered potentially avoidable hospital admissions or ambulatory care sensitive, what of those have the most spending? And so if we click to the next slide now, these are the health conditions we decided to focus in on. So all of these health conditions were on the CMS list and the ARC list as, health conditions that generally can and should be treated in an outpatient setting. And they are health conditions that we have all the necessary data for. And by that specifically, I mean we have the utilization data and the disease prevalence data. And so back to Eric's point, we can now kind of look at this as not utilization per capita, but instead we can look at utilization per prevalent case. So per person living with this health condition. So if we focus on diabetes, in a moment I'll be showing you figures of the utilization of outpatient or hospital admissions for diabetes per person living with diabetes. So now we're essentially conditioning out some of the differences in underlying health that comes when you look at different counties across the state. And so these were the 5 health conditions that we decided to focus on. The top 3 were all in this list from CMS and ARC. The bottom 2 were just behavioral health conditions. And when we presented on this work before to different groups, we've gotten the feedback that it's really important because it's such a priority for the state and because it's some of the health conditions that have spending growing the fastest, that we also look at behavioral health conditions. So we chose to look at diabetes type 2, chronic obstructive pulmonary disease, asthma, alcohol use disorders, and opioid use disorders. And collectively, those make up just under 10% of all healthcare spending in the state. So, this is by all means not representative of all the spending, but these are health conditions that we spend a lot of money at. You can see in all the cases, it's hundreds of millions of dollars between private insurance, Medicare, and Medicaid, and out of pocket that is being spent on these health conditions. So the next series of slides that I'll show you are very similar to the first set of figures that I already showed you, but now they're focused just on these 5 conditions. And instead of looking at per capita, everything is in per case terms. And so this first slide is looking at the relationship between inpatient admissions on the x-axis and outpatient visits on the y-axis. And the upward sloping line kind of hints at what we saw before, which is that there's not a huge amount of trade-off. In fact, there's kind of the opposite. The counties that per prevalent case are using more outpatient care are also the same counties that are using more inpatient care. And that is, true for all 5 health conditions. And this, we didn't start with 8 and then try to tell a convincing story and parse out the other 3. These are the 5 that we've been analyzing throughout. And we see this really clear relationship that, again, the places where outpatient care is the highest is also the places where inpatient care is the highest. And you can see some of these are steeper lines than other, but in all of them, it's kind of this upward sloping line that, again, that in some ways hints, an economist would say that these are now kind of, they must be complementary. There's not a trade-off between the 2. And so that's what we're seeing. So that really begged the question, well, where are these counties that are having higher, especially inpatient care, now that we're looking in per prevalent case? And so the next slide is a map for each one of these health conditions. And I know the font is really small here. The numbers aren't all that important. The important part are the colors. The greens here for each health condition are where the hospital admissions per prevalent case are lowest. And the purples are where the hospital admissions per prevalent case are the highest. And so I think the objective of looking at 5 maps at once is not to, to try to tell a story about any one county per se, but more to start to look at for trends. And so the thing that jumped out to me and my team was that some of the counties that are, green are green in a lot of these figures. And some of the ones that are purple in a lot of these figures. And it suggests that across these diseases, some counties are essentially having more inpatient admissions for these potentially avoidable hospitalization causes. And that it's common across diseases. It's not just one disease here and one disease there, but instead you see some patterns that the counties with the highest admission rates kind of persist across all of the conditions that we're looking at. So that begged the question, what do these counties have in common? And so I have two last slides, and I'll push through them quickly. This slide is looking at urbanicity. And so unfortunately, we switched it here. Now rural is on the left and urban is on the right. But you can see that as a county becomes more urban, meaning they're more to the right on the x-axis, their hospital admissions per prevalent case goes down in all of these. And so this is that relationship we were seeing before, that hospital admissions are lower in more urban environments, and they are higher in rural environments. And I think a number of people have already commented on why this might be. But the important thing here is we're conditioning out the underlying health of the community. So the disease prevalence is controlled for. Emily, I saw you have a question on the last slide. So let's go back. Thanks for asking. If we go, yeah. So the green here is low. And so the scale for each one of the maps is a little bit different, but green is always the lowest quintile, meaning it's the set of states that have the lowest hospital inpatient utilization. And so as it goes from green, dark green, to light green, to white, to light purple, and then to the darkest purple is the counties with the highest admissions for these select 5 health conditions. So the goal here is, again, not so much to say, oh, this one condition for this one county for this one condition is really high, but more to look for a general trend across the 5 counties. And I certainly see some counties. There's some outliers, but generally, the counties in the southeast, for example, there's a cluster have in most of the figures relatively high purple values, which is to say they have relatively high hospital utilization rates for these 5 diseases. And while it's not true for alcohol use disorders, the kind of I-5 corridor, and especially the Puget Sound minus the Olympics, Pierce and King, some of the more urban parts of the state, tend to have more green values, which is lower utilization of hospital inpatient care for these 5 health conditions. So great. And so that brings us to the next slide, which we talked about. I'll just restate, is that essentially as counties become more urban, they have lower inpatient care for these 5 health conditions. And now if we go back and one slide forward, this last slide is looking at income. And what we found in our analysis is that income wasn't particularly related to inpatient care, but it was related to outpatient care. And so you see this upward sloping line with it for everything except for opioid use disorders is kind of the outlier here. But as counties get wealthier, they have higher inpatient visits per prevalent case for most of these health conditions, in particular for diabetes, COPD, and alcohol use disorder, a little less for asthma and opioid use disorder. But in general, we're kind of seeing this relationship with more income is associated with more outpatient visits for, again, these health conditions that we believe really should be treated in an outpatient clinic. So that brings us to the last kind of concluding slide. I want to be mindful of time. So I kind of boiled down 2 takeaways, and this is the takeaways both from the aggregate analysis as well as the disease-specific analyses. It was number 1, we don't see a clear trade-off or relationship between outpatient visits and hospitalizations. That's what we instead see is, especially in the disease-specific analysis, that there's a positive relationship. So the places that per prevalent case have the most outpatient visits also have, in per prevalent case, the most inpatient admissions as well. And then the second point, I think, is really important. Again, this is more focused on the disease-specific analysis, but it says that there are, in the rural counties, more inpatient admissions, and in the wealthy counties, there's more outpatient visits, which again, I think is, a number of people have already commented to the point that we have, some kind of really important trade-offs, and that these counties are fundamentally different. And so that brings us to the last slide, which is, I think, just our conversation points. So these were two of Harrison's questions. I know we have only 4 or 5 minutes remaining, but want to leave space for any additional questions, or if people have thoughts about these discussion questions.
Thank you, Joe. I just wanted to note as well that Dorothy Teeter had a question in the chat.
I'm sorry, Dorothy.
No problem. Is addressing practice variation across counties within the state part of the solution is Dorothy's question, Joe?
I don't think I can answer that question. I think that I think it's an tremendously important question, but not one that I'm able to answer. But I mean, I think certainly what our data and estimates are hinting at is that there is an access issue. And again, when people ask what to do with these data, I think they're really primed for being able to say where there are gaps in coverage. And there can be lots of reasons for those gaps, but I think our study is starting to hint at where those gaps exist.
All right. Well, this is great, Joe. And so as you put up here in terms of some discussion questions, these are back to the committee members to try to hopefully provide some thoughts. I know some folks have already kind of commented on their own personal experiences and how this is playing out in their own communities. But Emily, I saw your hand up. Did you just put it down? Do you want to chime in?
Yeah, I did have my hand up. Thank you so much. This is very interesting information, and I can see everyone's very engaged in the chat as well. So looking forward to hearing from others. One question that I have, and this is a bit outside of the scope of what you covered today, but you have also analyzed healthcare spending, and others have analyzed healthcare price trends at a county-specific level. So I'm wondering if you see correlations between the outpatient and inpatient utilization that you discussed today and some of the price and spending information that we've reviewed in previous discussions.
Yeah, great. Thanks for asking. So in this specific analysis, we were just looking at utilization with an eye towards, identifying gaps. But in general, we see when we look across all the counties, not just Washington State, we tend to see some, for all the types of care, we see, hints of a trade-off, that places that have the most expensive care tend to have lower utilization rates. And that would fit with what an economist wants to see as far as a trade-off or between price and utilization, or demand in this case. So I think that tends to make sense, but for this specific analysis, we didn't dive into that much.
Thank you and I appreciate the way you frame that as an economist, because as a patient advocate, I may frame it, and tell me if this is wrong, thinking this way, as people who live in places that have fewer access also have more expensive care that they're facing.
Yeah. Yep. I mean, that is what we're seeing in many ways. Yes.
Joe, I'm sorry if I missed it. Can I just ask a question? How is comorbidities handled here? Could it also be that folks who are of low income may have higher comorbidities, or people living in rural areas may have more comorbidities because they aren't being addressed earlier?
That's a great question. So in our study, we purposefully reallocate the utilization to the, if someone has multiple comorbidities, the utilization is still more about their primary diagnosis, about why they visited, and we're not doing any sort of risk adjustment here. And so it's very possible that more complicated cases exist in some places. We're adjusting in the disease-specific analysis for prevalence, but not for the prevalence of other diseases. And so I think that's a great point that could be another kind of part of this additional steps of this analysis. Yeah.
Right, because the higher cost of care could be associated with the fact that either they have more comorbidities that may be exacerbating that particular condition, or
Exactly.
other services to be provided.
Yeah.
Hunter, I
Absolutely.
see your hand is raised. Oh, sorry.
Yeah, and Bianca, you actually kind of spoke to exactly kind of the point I was going to raise in terms of like the comorbidity, because just when I'm looking at kind of at least slide 33 on the handbook, yeah, just the reason why you see that kind of correlation still between ambulatory and inpatient is, even though if you're controlling for the disease prevalence of that given county, what that's more indicating, right, is that it's more likely that counties with higher prevalence of diabetes or others also likely have a higher, amount of like comorbidities that then is like kind of fueling the increased, healthcare kind of utilization. So to me, that kind of reconciles. And yeah, you just need to go a little bit further with a case mix, control.
Yeah, no, I think that makes a lot of sense, Hunter. And I think 2 years ago, when we thought about this project, one of the things we talked a little bit about was to do some kind of indirect risk adjustment based on characteristics of the county, and that we didn't end up going in that direction. But I think what you're saying makes a lot of sense, and might be part of the story that's going on. So, Eileen?
I'm just curious whether there's any way correlation, or if you've looked at this, about how much money is spent on public health in the different counties, because to see whether that's a better way, if we think about where we want to spend our money, should we be putting it there and hopefully be able to reduce some of the other expenditures?
So we have tried to do this at the national level, not at the state level. And tracking spending on public health programs is really hard. The project that we undertook with county level medical spending was hard, but I think the public health is even harder because the money comes from the state, but there's also local public health programs. There's federal programs. And so when we've tried to do this across all US counties, we've really struggled. It may be easier to do just a single state, because then you have just a smaller set of what you're trying to analyze. We have not done that analysis because we just simply weren't able to get the data in order to look at it. Yeah, thanks for asking.
It looks like maybe we'll take one more question perhaps here from Adrienne, and then I think we may need to move on. Okay, great. Yeah. Adrienne.
I was saying if we could do, since I work in public health and represent public health, we are putting money into those rural areas as much as we can. And yes, the money does come from the federal and state level, but that money is stopped and will be not happening anymore, as we know, with all the cuts and then the state deficit. So this is what I brought up in the last meeting. I would like to know and have an analysis then of what this means. If we are not there to do prevention and we are not there doing the services that we've been trying to do with, limited resources and not having resources anymore, what does this mean?
Yeah. Thanks, Adrienne.
Well, thank you, Joe, for your time and for presenting this work and for everyone's questions. So I think we'll hand it back to Ross.
Thank you so much, Bianca and Harrison and Joe, for that fantastic presentation. Greatly appreciate it. And just wanted to again shout out Harrison and our data team for all their work putting together those preliminary slides that we went through before Joe's discussion of the data. As I know, we've gotten a lot of questions in the past trying to understand how those different data streams interact with one another, those being the on-point cost driver, the ASI data, and our data call. So I know we didn't have a ton of discussion time around those, but if folks are reviewing and have any questions related to that, happy to answer that and hope that was helpful for folks. And again, thank you to Harrison and the data team for their work on that. And thank you, Joe, for that wonderful presentation. And now if folks are willing to turn to tab 5, we're going to begin our discussion of hospital expenditures. Harrison's going to start with some data related to hospital spending, and then I'll discuss a few strategies to limit cost growth that was discussed with the cost board at their last meeting. And then Eileen will lead us through a discussion. We're seeking some input from this group on what you'll see are referred to as policy levers. And so really looking forward to that presentation. And now I'll turn it over to Harrison.
Thank you, Ross. Hello again, everybody. So we can go to the next slide. So today I'll be walking through essentially an abbreviated version of a presentation that the board saw in late April, and hoping to get your thoughts on some of it from a stakeholder and data perspective. And so as framing, the cost board has several legislative directives. You can see a few of them here. Part of what the focus is to identify cost growth trends and analyze total healthcare expenditures, and really importantly, to use that data to provide policy recommendations to the legislature, not only to increase transparency, but also to improve affordability and to, push forward systems wide change that improves affordability for all Washingtonians. So that's what we'll be talking about here. Let's go to the next slide. So in front of the board, we walked through a few different slides along these lines, but what you see here is commercial spending growth by service category, and you see this in sort of two different versions. You see in this left line graph here, on the y-axis, we have total medical expenditure. X-axis is time. So we're looking across time, and each of these different colored lines is a different service category. So for example, we see hospital outpatient and hospital inpatient, those two lines up at the top of the chart, accounting for a substantial amount of overall total medical expenditures within the commercial category. And we can also look at these expenditures by total growth over a certain time period. And so that's what this stacked bar chart here on the right is referring to. And so this is looking at a time period from 2019 to 2022. And what we see there is we can also pull out sort of the top contributors to, in this case, not overall spend, but spend growth. And when we sort of make a short list that's, the top three that are from overall spend and the top three from overall spend growth, or sorry, contribution to spending growth, we get this list here that we see on the left. And that shows it's fairly consistent across market categories. And we see hospital outpatient and inpatient, as frequent contributors. We also see prescription drugs and professional specialty, especially when we're looking at this in this commercial sector, as major contributors. When we consider these as potential targets for policy interventions, it's important to note that the Prescription Drug Affordability Board does have a lot of good work and is moving forward the ball on addressing those escalating prescription drug prices and overall expenditures. And so this would suggest that it might make sense to look at these other categories for policy movement. And specifically in the next slide, we'll dive a little bit deeper into hospital spending in Washington specifically. So next slide, please. So this slide here is essentially providing a top-line summary of a few different studies that the board has seen across the recent years. The first of which showed that price and cost are higher for Washington hospitals, a specific group of Washington hospitals, than for peer hospitals. And additionally, we see that the commercial reimbursement rate, this is a RAND study we're referring to here, was approximately 2.5 times what Medicare would pay for those same services when we're looking at hospitals across Washington. And then lastly, price per service increased when we look at our cost driver analysis across all markets, but especially within the commercial market from the time period of 2017 to 2023. And I believe I saw a hand. I don't know if it's still up. Eric, go ahead.
Yeah, you mentioned inpatient as being a big driver. If you go back to your last slide,
sure.
I see inpatient as a the way I look at this, inpatient has really contributed to lower healthcare costs. It's only gone up 0.1%. So why would you say that's a driver?
That's a great question. So in terms of these two different ways that we can consider, what is contributing to overall spend, although it's not contributing to spend growth, I think it's certainly clear that from this chart here on the left, that it is a major contributor to overall spend, which is to say, if we're considering potential ways to reduce healthcare costs and improve affordability for Washingtonians, it makes sense to at least consider the contributions of the major sort of pieces of the overall expenditure pie.
I would just point out on inpatient, of course, with COVID starting in March of 2020, there was a whole new disease that resulted in a lot of inpatient stays. So that's not hospitals' fault. That's a function of population health and diseases in our population.
Certainly.
Appreciate.
Well,
Yeah,
this is Chris Dable. I'd add to that I don't know that you can dissect them like that just because there's so much crossover from inpatient to outpatient during that time frame. So as I'm looking at this too, and as I've spent time on this, I've actually provided feedback on this particular topic that the growth in hospital spending over that period of time is very small. And so I don't want to conflate two different topics either, that one's growth and one's the overall spend, because of course hospital spend is going to be the biggest spend when it comes to healthcare. I mean, it is the most expensive aspect of healthcare, but it's not to be confused with growth over this period of time, because I think it's actually notable how small it has grown over that period of time when you combine the two services.
Thank you. And I'd like to remind folks to please raise your hand in advance of speaking so that we can keep the meeting proceeding orderly.
Yeah,
Harrison, I'll throw it back to you. Thank you.
Yeah, appreciate those comments. Certainly see a lot of hands up. Essentially, yes, I would say that it's important to consider all of the factors that contribute to spending and spending growth, and certainly noted Eric's point that this time period that we are looking at to spend, depending on how you slice and dice the data, does include COVID, and that's a major factor to consider. And certainly, this is using the data to just consider what are the major contributors, and use that to inform our potential policy options. But certainly, that's the subsequent part of the conversation. But I appreciate the clarifications, and let's go to Emily.
Thanks. Well, I appreciate pausing on this slide because it is very interesting, and I also want to just give appreciation to Eric's note that it's nobody's fault, right? We're looking at the data together. One of the things that I had that same question, so thank you for asking it. One of the things that I've been looking at and trying to puzzle apart here is policy-wise, we have been encouraging outpatient spending, right? That's been kind of a goal to transition to more outpatient care where possible. And the thing that kind of strikes me in this, looking at the trend lines and curious for others' thoughts, is that I think we would have expected some kind of trade-off, right? If we're spending more in hospital outpatient and we're spending more in prescription drugs, the idea behind that policy-wise at a high level is we're supposed to be keeping people out of the hospital. And so maybe, as Eric's saying, that there's a blip, and we want the hospital inpatient to be like holding steady or going down, given those other factors, if we're trying to shift as a policy community, shift spending to more appropriate settings, if possible, preventable settings. But we're not quite seeing that trade-off. And I think maybe some of that is COVID as we're looking at that time period. So it'll be really interesting to keep an eye on that. I don't think COVID explains all of what's happening here, because we also saw that during those years, people were avoiding outpatient care if they didn't have to, right? So there's something kind of funny going on there. and appreciate the chance to puzzle on it with this group.
Yeah, thank you for that, Emily. Definitely appreciate the point that we don't seem to see outpatient spending trending up at the same time as inpatient is trending down. I'll note that there was also a rudimentary utilization analysis looking at exactly that question of do we see a trade-off. At the high level, it seems like we don't see according to that analysis, major sort of shifts from inpatient to outpatient contexts, but certainly could use some further looking. And I see Jonathan has his hand up. Let's go to Jonathan.
Yeah, I just wanted to make the point about the intensity. I think when you look at this, you can see the intensity of the inpatient care going up. Those younger, healthier patients are getting care in the outpatient setting, but those that have those more complex comorbidities are actually remaining to get their care in an inpatient setting. So if you looked at length of stay just as an easy way to compare this over this time, you would see that length of stay go up dramatically. And that has a lot to do with the intensity of care that is remaining within the hospitals here. Just keep in mind, and we've said this in the past, that Washington State, the beds per census is the lowest across the country. We are ranked number 50 when it comes to that. So the inpatient setting does play a role in this. But when you're looking at the intensity of the care, I mean, just looking at length of stay alone, you're going to see an increase over the course of the time frame that you have here, suggesting that that has gone up over time. And you'll see more of that care being set in the outpatient setting. If you used hips, for example, those that have more complex comorbidities are remaining to get those in a hospital setting in inpatient. But if you look at those that are healthier that don't require that much care, you'll see that they're getting the care, which would explain why you're seeing an increase in the outpatient volume. So I would recommend you looking at it not just overall, but by condition, by service line, really drilling into it to fully understand what's taken place.
Thank you for that. Great points. Just quick clarification. When you say looking at hips, is that an allusion to looking at hip replacement?
Yeah, like large joints, hips.
Okay,
That's just
okay.
an example.
Just wanted to
But
make
yeah,
absolutely
I mean,
sure there. All
there's
right,
other areas that you could obviously look at, but that's just one of them.
great. Thank you for that. Any other comments on this slide? Thank you for the rich conversation. All right, if there are no other questions, we can keep on moving. I think we're a few slides down. There we go. So this all sort of brings us hopefully to why focus on hospital spending, or at least why consider focusing on hospital spending. And the trends that we showed for Washington State aren't really specific to Washington State. They're something that we're seeing across the country. And especially if we look at other Peterson-Milbank states, essentially other states that more or less have a cost growth benchmark, they have also identified hospital spending and particularly hospital prices as a major contributor there. Quick technical point, when we're talking about prices, we're really talking about prices in terms of payment per service unit. It's easy to get sort of turned around with the different things we could mean there. And I see we have another hand.
So this is Krista again. I'm just interested in where that data is coming from, because the on-point analysis for hospital pricing was split out between utilization and pricing. And if you looked at the commercial pricing, which is, when you're talking about Medicare, Medicaid, there's really no pricing. It's basically, the price is the price, right? So there's the commercial pricing. But the data that I've been looking at from On-Point that's from this group has indicated that over a 5-year period of time, it was about 2%. And so I'm wondering, when it says hospital prices were the #1 driver of commercial market spending, where is that data, the source of that data coming from? Is that specific to the Washington data that was pulled, or is that kind of national trend data?
So for this slide in particular, the source is the Healthcare Cost Institute. I will say that, right, the trends that we're seeing nationally are, roughly what we're seeing in Washington. Does that answer your question? The
Yeah,
source here is the Healthcare Cost Institute data.
Yeah, I would challenge that they're the same. I would challenge that using national data is we have drill downs and we're looking very specifically at Washington pricing. So why would national data be used?
Right. I thank you for
Harrison, maybe can I offer?
Yeah, go ahead, Bianca.
It seems like the main point of this slide is just to kind of situate or provide some context, like why has hospital been the focus here in Washington? And it's been driven by the fact that nationally, hospitals have been a source and has been identified as a major contributor to overall national health spending trends. So I think this is partly situating why the focus here. And so, yes, you're probably right that there's some differences to consider here in our state. So I don't think our goal here is necessarily to compare between the two, but to mostly put context to why hospitals have been such a focus.
But if the hospital pricing in our state hasn't been a cost driver and all of the focus on this committee is based on controlling pricing for hospitals, then are we focusing in the right area?
Yeah,
well, and I think we're talking about both hospitals being outpatient and inpatient, right? And I think some of these data are also like, from my own personal experience looking at hospital spending data nationally, I mean, inpatient is oftentimes a part of the conversation, but I think here we tend to be talking more about inpatient plus outpatient, and outpatient has been increasing.
And I'll echo that statement. And I think much of our cost driver analysis work also points to hospitals being a significant cost driver in Washington State as well. And I see we have Julie with a hand, and also want to remind folks we do have a discussion period at the end of this presentation too, as I think this group will really be interested in discussing and commenting on the policy levers that were proposed, and just wanting to make sure we're preserving some time for that as well.
Oh, thank you. I'll go quick then. I wanted this actually to comment on the last slide, and I don't think I got my hand up in time. But as we're discussing hospitals and we're discussing hospital cost, price, the driver, with policy levers, I still have never seen the analysis of what the Washington state law on guardianship has done to hospitals, our inability to discharge patients that no longer meet medical criteria, and those costs and those prices, and how that has impacted the overall drivers of hospital costs.
That's very interesting. I was not, that is not a piece of analysis that we've engaged in yet, but is certainly something that is interesting and could be something that we consider as we are working to identify policy levers through this process.
Maybe that's something in the discussion that we talk about. I'd be curious to see if maybe our hospitals are only impacted by this, but I've heard, that quite a few hospitals have patients that they can't get out because of discharge, inability to move them on, move patients on to whether it is to skilled nursing facilities or homes, the unhoused population. So it may be something that I have heard is an issue, but it really isn't. But I do believe there is significant cost associated with that.
It's a fantastic point. I know difficult to discharge is a category of concern for lots of hospitals, and that is a significant issue. So thank you for raising that, Julie. And
Let's
Dorothy,
go.
please. Yeah, sorry, Harrison. Dorothy.
Go ahead, Dorothy.
Thanks. Just a really quick question on this particular slide. I was thinking this was representative of Washington State, but I'm rereading the labels. Is this a national picture, or is this actually Washington State?
For this slide specifically, we're talking about a national context that
okay.
set aside the Washington State context that we've walked through in the previous slides. And I will note that there is some more detail in some of the slides presented at the board, if that would be interest to folks on the committee. I'll note that we have 5 minutes left in this segment, so let's let's move along here. Thank you for the comments, and certainly looking forward to getting to that discussion at the end here. So I believe we've covered this. Let's go to the next slide, please. So bringing this to our sort of current state, where in the state of Washington, we have a cost growth benchmark. And that cost growth benchmark is based on primary care attribution. So the way it works is total medical expense, and the accountability for that total medical expense is assessed on essentially a patient's connection on their attribution to a primary care provider and their affiliated group. And so what that misses is essentially patients who are receiving care at hospitals that are not affiliated with their contractually affiliated PCP. So we have an issue here where the current mechanism to control cost growth in Washington State is not does not really have line of sight to one of the potentially identified major drivers of that cost growth. With that, I'll hand it over to Ross. I see lots of comments in the chat. We have a few more slides to get to, and then we'll have some more time for the discussion. Go ahead, Ross.
Thank you so much, Harrison. Emily, I'm just following the chat. I think Amanda's response hopefully addressed your question. Okay, great. And Audrey, would you be able to advance? Thank you. And as Harrison talked about, his portion of the presentation was trying to orient folks to why we were looking into hospital expenditures, hospital spending, as a way to move the cost board from some of the analytic data functions into making some policy recommendations to bring about some change. Part of the presentation that we had from Michael Baylett at Baylett Health was this idea that cost growth benchmarks, which we have in Washington State, are not enough in and of themselves to constrain cost growth, and recommending that states look to some of these policy levers, and we'll go through a list of potential policy levers as a way to really actualize these changes. The visual here is kind of just identifying the different work streams that we have at the cost board, measuring, analyzing, reporting, identifying, and this is really getting at the implementing and identifying phases of identifying the problem and trying to look for a solution to these. So if you could go to the next slide. So these are the potential policy levers, as they were referred to by Michael Baylett. I think you could call them policy actions as well. They were bucketed into 3 general categories. I'll run through the first, those of which that are tied to or related to our cost growth benchmark. The first being publishing data on hospital prices and price growth and naming names. This is pretty similar to what we do currently in terms of publishing hospital prices and price growth, and naming names to a certain extent, identifying those carriers, provider organizations, or entities that exceeded the annual cost growth benchmark. Currently, that's 3.2% annually. And so this is part of the process that we do currently. The second option is creating another option for policy action is creating a complementary hospital price growth benchmark. That would be something in addition to the more general cost growth benchmark that would specifically be tailored for hospitals. And that can be done in a very nuanced way where there's a difference between, for example, rural hospitals or CAUS compared to our more urban hospitals. The idea for that is that there may be some subtlety that having a more targeted hospital price growth benchmark is able to provide, one, a little bit more nuance for hospitals, but also some closer monitoring of a hospital price growth. The third one is a really interesting option, and I'll acknowledge a little bias coming from our state certificate of need program. But the idea with this, number 3, is that currently the Washington State's cost board does not have enforcement authority, meaning if a facility entity exceeds the cost growth benchmark, there's not any type of enforcement action that would be carried out. what number 3 is proposing is putting the cost growth benchmark currently set at 3.2% onto a certificate of need, which was issued to all hospitals in Washington state. So this would be put on their individual certificate as a condition, such that if the hospital did exceed that growth benchmark via the certificate of need program, there could be potential enforcement action taken, as that would be a violation of a condition on their certificate. I'm not aware of other states that have specifically moved forward with this type of proposal, but it does introduce some really interesting, a really interesting concept of partnering with the certificate of need program and potentially the guide for that program, which is the state health plan, and trying to tie some of those standards into a more overarching type document like the state health plan that implements certificate of need. Moving on to independent but complementary. These are that take direct action on hospital pricing issues. This would be less of a global solution and more of a issue-specific, facility fees being a prime example. The cost board has highlighted in last year's report some concerns regarding facility fees and some of the burden that puts on patients. I'll note that when this was initially presented to the cost board, there was some hesitancy about an approach like 1 or like 4, like I'm mentioning, due to the lack of kind of a global nature of it. It's very issue specific. And so some concern about this not really getting at the heart of the problem and more so trying to act at the periphery. Going to 5, establishing a hospital price growth cap, and that is complicated in nature, but quite straightforward in what it's trying to accomplish, which is setting a cap on the amount of growth that would be deemed acceptable for a hospital, assuming that there would likely be some type of enforcement mechanism tied to a hospital price growth cap. So the state would be able to take action if a hospital exceeded that. Clearly, that would require legislative authority to move forward on. Quickly with 6, setting a hospital price cap, aka reference-based pricing. This is one that I certainly imagine that we will spend some time discussing at the cost board level because of Senate Bill 5083, which was signed Tuesday, by the governor, which puts forward reference-based pricing for PEB/CEB benefit plans. So we will get some ability to monitor and get some understanding of reference-based pricing, at least in that market segment of PEB/CEB. And I guess the question for the board and these committees is there any interest in potentially expanding that beyond what 5083 recently passed? Finally, an independent idea, which is prospectively reviewing and approving hospital revenue and or price growth. This would be kind of cited as the most extreme example of something where the state is actively reviewing and kind of approving hospital budgets growth. I think this could take a variety of forms, but I think if you were looking at this on a spectrum, this would be perhaps the most invasive, but that would also offer the state the most control potentially over cost growth in this sector. And just before I transition to questions, the cost board also noted interest in adding an additional option to this list, which was hospital global budgets. Again, speaking to the more global nature of trying to address the issue. And so that is something that we'll be presenting on at the cost board at the next meeting, as we didn't provide a ton of information on that, just for some thinking for folks. So Audrey, if you would transition to the next slide, and I believe Eileen will guide us through some questions. And just before I drop off, just to say what we're hoping to get from today's conversation discussion, by no means has the cost board or moved forward with any of these policy levers. And really what we're hoping to get from you today in your advisory capacity is the type of information you think it would be valuable for cost board members to know about these. And we have some specific questions to try and pull that information out. But I just want to reiterate again that nothing has been decided yet, and that we're very much looking forward to bringing this information back. And I'll give it to you, Eileen. Thank you.
Okay, thanks. And thank you, Harrison, also. And after hearing these presentations, we would like to hear from you. But I'm going to say, since I know that we're getting short on time, that you also might want to send in responses to the email that was put into the chat. But I see we had Julie Sylvester, you've had your hand up for a little while.
Yeah, I found some of the policies on the certificate of need tying the hospital's cost increases to their certificate of need. So just so I understand this correctly, so if our costs go up higher than, say, the 3.2, you're saying our certificate of need would be jeopardized?
Well, in theory, if this was the idea that was proposed, and perhaps there would need to be some legislative changes. But yes, the kind of the end route of that would be that if a new
So would that give hospitals then the flexibility to say, you know what, we've got to keep under a 3.2, so we can't treat this subset of patients that historically has higher costs. Maybe they don't follow their discharge guidelines and they're going to be readmitted. Maybe they're drug seekers. Maybe they're, I'm sure I could list 20 things right here. So would hospitals then have the flexibility to start moving in and out of making decisions of patients that will potentially jeopardize or increase their costs? I mean, is that what we're going to do?
I think that would probably be outside of at least this recommendation, but I guess that would potentially be part of the conversation that would need to be had about this topic. But I know that there are other obligations hospital has in terms of serving patients and serving all patients regarding of ability to pay with our charity care laws. So I'm not sure if we're going to be best positioned to answer that right now, but I can imagine that conversation evolving. Sorry, Eileen, please go ahead.
No, I was going to say you could also, I mean, it could be prospectively that it's like you get extra points if you actually have consistently been under the benchmark when you apply for a certificate of need going forward. And it would help, there's different ways that it could be implemented.
So let me ask you this, would this also then impact our ability to use advancements in high cost drugs, technology, devices? All of these things are significant costs. They contribute to the highest quality outcomes, whether they're surgical, preventative, so would we begin to look at like drug utilization for like the cancer patient, the transplant patient?
That we're looking at the drug prices in the prescription drug affordability, which I just happen to be on that little group too. So drugs that aren't in the purview of this group, that we have left that to the prescription drug affordability board.
Well, these aren't prescription drugs like, you go to Rite Aid and get them filled.
No, I know all of the drugs.
Okay.
No. Specialty drugs.
Yep.
Yeah.
Okay. Okay. Thank you. Thank you for letting me ask my question.
Okay. And then Eric?
Yeah, hello. Thank you. I look at those policy choices, all 7 of them focus on paying hospitals less. And I think as you look at capping revenues to hospitals, I think it's important to look at the impact on hospital financial stability, and also look at will these policy changes impact a reduction in services and hospital and access for patients. I think I've been a hospital operations for over 30 years, and I think just staring at revenues doesn't get to the challenge that hospitals face. Hospitals face when you run a hospital, you have a lot of expenses. You have people, supplies, drugs, and everything else. And hospitals operate in the free market, meaning they have to buy and pay for things at fair market value. There's been tremendous inflation on hospitals from 2022 to 2024, about an 18% increase in the cost of hiring employees, paying for medications, paying for supplies. So if you just cap what hospitals get paid and the underlying inflation that hospitals are experiencing continues, I don't see how hospitals are going to stay open or how they're going to be able to maintain their services. And so I think it's, we want to control healthcare costs, we're going to have to look at the expense side of hospitals. How can we help hospitals control the expense side? And what pharmaceutical companies do would be one area to look at for sure. But I can tell you the cost of employees is 60 to 70% of the cost of running a hospital, and inflation on healthcare wages. I mean, the healthcare unions have been very successful. Is significantly higher than 3%. So I think the policy levers are just going to focus on hospital revenue, and you should definitely think about how it's going to impact viability and access for patients, and how hospitals can control their costs might be something that we look at beyond the policy choices we just had.
And thank you so much, Eric. I would love to, if you would have any willingness to maybe put forward that idea you were mentioning, looking at maybe a different way, because this is not intended to be an all-inclusive list of policy actions, but from your perspective, maybe a different approach that could be taken maybe on the expense side that would also look to, contain costs in this area. So would certainly welcome that. Thank you. Thank you.
Okay. Yeah, I think we'll work on that.
Right. And I would remind you, Eric, that it is the cost growth benchmark is for all of healthcare. It's just that hospitals are where a huge percentage of healthcare costs.
But is it for pharmaceutical companies, supply companies?
You know that I go after.
No, I know you would, but also, healthcare unions. Is it for them?
Well, they have to get factored in.
Okay. Thank you.
I see
Do we have other hands up? Let's see.
We have 4 hands now. Let's have these be the last 4 hands because we do have another segment to get to.
Is Julie, is your hand still up from before?
Yeah.
Okay. Critton and Bob. Dr. Bob.
Hi, thank you. On Eric's point, I kept pondering all the suggestions that are on there, and I agree with him on that we focus a little bit on how we help or how hospitals can make the adaptations. I've worked in a number of hospitals. I know they're complicated. I also know that our prices have been just skyrocketing, for years. And so, it would be nice to not just put a cap on, but have a way to help them if they manage their pricing or their costs and their prices eventually. And I'm reminded of the couple different things we've done. The primary care kind of collaborative, the diabetes, whatever they call it, collaborative, where we actually help providers get together and work out ways to address certain issues. I just put that on the table as something to think about. And that's all I wanted to say. Thank you very much, Ms. Chairman.
Okay. David Giuseppe?
Yes, thank you. Sorry, my camera's not functioning today. Just a few comments. I like to think of this through supply and demand when we look at, what's driving the overall total cost of care. And the demand side, I think, is the amount of services that we all seek and utilize, which feels to me like it's largely outside of the control of the cost board, which takes us to the supply side, which is the unit cost side. So it feels like it's fair game for the cost board to be asking these questions, not only of hospitals, but of pharma and health plans and everyone who's contributing to the cost. And, just superficially, I think many of us have had the experience where, pre-deductible, we might pay $400 for an X-ray or $700 for a 10-minute procedure. And so it feels like the cost is higher than it needs to be. But I think the point of these kinds of analyses are to study what the implications would be of implementing some of these policies, and then to be able to talk through with the different stakeholders, can those implications be absorbed or not?
Okay, thanks. Emily?
Thank you, Madam Chair. So I want to just kind of bring us up a level for a moment, because we can get heated in this space, and I'm guilty of it myself. I think we need to remember that the reason why we're here in this space is that consumers cannot pay for the healthcare costs and spending that we have right now. That we're in a baseline position, and the information that we have, both from state and national data, shows that the consumer is struggling with affordability, and has been for decades. And so I think the point of the cost board is to say, let's try to put the lid on collectively. Let's try to only stick to this this percentage, and what can we do together. Now, I think we've had a discussion today around not wanting to point fingers, and also wanting to make sure, as Bob pointed out and as others have pointed out, that we're having a kind of productive dialogue. I really support the idea of coming back and having a discussion about what is happening with healthcare prices and costs, and laying some groundwork there that looks at the differences between some of Washington hospitals, who is doing a great job, and how they're doing a great job at keeping spending and costs down. And I think that kind of positive discussion that we really need also needs to be paired with a recognition or an understanding from all of us that consumers can't keep paying for the prices and the costs to keep going up and up. So it's not an option for us to spend years delving into to that analysis. We need to spend some time on it, and we need to also then be thinking about how we move more quickly towards a solution.
Okay, well, we need to get moving. So Ross, I'll give it back to you.
Yes, thank you so much. I'm looking through these comments now, just so grateful for folks' willingness to participate in this conversation. We'll review those. Please feel free to send any additional comments in writing. Next, I invite folks to turn to tab 6, where we will have Daniel Garcia, our legislative analyst, provide an update on the 2025 legislative session. Daniel, I apologize in advance for the short time. Folks, if we're not able to get through all the slides, again, encourage folks to reach out with any questions after the meeting if we're not able to get at any. And Daniel, do we have you on?
Yeah, I'm here, Ross. Thank you so much.
Perfect. Thank you, Daniel.
Yeah, I can just jump right in. Hi, everyone. My name is Daniel Garcia. I'm a legislative analyst at HCA, and I work with Evan and Sean, who you probably are all very familiar with. And we can jump right in and talk about the last legislative session. Next slide, please. Yeah, thank you. So the legislative session adjourned on time. We avoided a special session for now. It was a long session, and we set a biennial budget, and the unbalanced budget and budget negotiations were really what set the tone for a lot of what got funded and didn't, and the policy bills that came out of the session. And so that's what I'll talk about today, including our agency request legislation, and also some policy bills relevant to your work. Next slide. So the priorities that we went into a session with just include all of these. I won't read all of them, but just want to highlight things like Apple Health expansion, True Blood, SUD, also paying attention to rates in areas like maternal access, and also making sure that our IT projects like 988 and the electronic health records, EHR, were some of those priorities. Next slide, please. This slide just gives you a snapshot of the type of work that we did this session, and just reflecting the increased fiscal notes that we got this session, but also not as many legislative reports, again, due to those budget negotiations. Next slide, please. So HCA was lucky enough to have 4 successful agency request legislation bills move forward. The first 2 of these are most relevant to the cost board's work, and the last 2 were included more just for awareness. Next slide, please. Yeah, so 5083, this was an agency request legislation related to PEBSEB affordability. And starting in 2027, there will be some caps for reimbursement on hospitals in Washington. You can read in the details there about the specific numbers. There's, of course, differences between in-network, out-of-network, also children's hospitals. And then also there were some hospitals that were carved out completely, and you can find a whole list of those in our fiscal note that we modeled for. And also we can follow up with that if anybody wants to see those. There are also 2 legislative reports in this bill in 2030 and 2034. And the real point of this bill is really just to align with the cost board's other primary care work and align with the prime sponsor, Senator Robinson's other work and her other bills in this area. Next slide, please. 1382, this is another agency request legislation, and this relates to PFI, proprietary financial information. The PFI definition will change, and I think that this is something that the Data Advisory Committee probably will have a lot of interest in, and also envision that this is an area where the agency might engage your all work much more because of the additional information that this bill allows HCA and the APCD to share, especially as HCA can now could function as the lead organization for the APCD. Next slide, please. So these next 2 agency request legislation bills are still relevant, but I would not say as relevant as the first 2 bills shared. The first, of course, is 5478. This just aligns the PEB and SEB authorities and what types of insurance you can kind of offer. So like a really fun one was pet insurance. That one got a lot of attention during session. And so this is another one of our agency request legislation bills. Next slide, please. And then finally, 1287. This relates just to care coordination and just allows for easier sharing of information between all of the types of professions listed here on the slide, and just allows for that easier, seamless share of information. Next slide. And so now we can jump into a couple other bills that also passed during session, not agency request, but still very important. So next slide. So first, 5084, this aligns reporting requirements with some stuff that HCA, reporting that already comes from HCA, and HCA purchase coverage, and just aligns OIC with what HCA is reporting on, just for consistency. Consistent reporting for things like supplemental payments, and also consistent methodology to track and measure progress towards things like that 12% primary care target. That's all I had to say about that. Thank you. Next slide, please. 686, this is the healthcare registry. So this is a perspective thing. This is a study only. There will be a progress update in 2027 and a final report due in 2028, just looking at the developing a plan of recommendations on how this could be created. And this is really important for knowing the distribution of providers in Washington State, and will allow HCA to do more work in the workforce space, and allows us to think more granularly about costs, and also will help the cost board, to know who a provider is and where they are. And so this bill will help with that work. Next slide. 5568, HCA, this is the state health plan bill. This bill really lives more with OFM, but HCA is involved with the state health plan and in the health resources strategy. This does relate back to the APCD and allows OFM to access some of that data in the APCD. And this is a big thing in that space that will be happening over the next couple years. There will be a couple of OFM reports included in this. From 2026, a progress update. 2027 will be the final report and policy recommendations and projections. And then in 2033, there will also be strategy updates starting. Next slide. 5493 is the final bill I'll talk about today, and this just aligns with federal policy. Beginning in 2027, this will have hospitals publish data compliant with the federal rule, and also submitting machine-readable files that list things like shoppable services to the Department of Health. The rationale for this was really in relation to compliance with those federal transparency regulations, and also with other reports that we've seen in previous years about hospitals. And the type of data required to be published could include things like price for common procedures and min-max negotiated rates, and which things hospitals are required to publish is really just more about that alignment with federal policy. Next slide. So that ends my presentation today. I tried to just speed through it, just given time. Other bills I didn't talk about that also just wanted to note real quick, though, would be other bills that we've seen in previous years, like the Mergers and Acquisitions Bill, commonly known as COCA, the Keep Our Care Act. There's another version this past session that did not pass, so didn't want to take too much time on it here. That was Bill HB 1881. Also, another bill that did not pass was the Corporate Practice of Medicine Bill, SB 5387. So two bills that did not pass, but that we've seen a lot of work on and are likely to see more work on in the future. And
Thank you so much, Daniel. Greatly appreciate the presentation. Sorry to condense your time. Thought you did a wonderful job. And again, kudos to HCA's legislative team for getting all 4 of their agency request bills passed this session. That's very impressive. Thank you again, Daniel. And I'll give it to Eileen to close us out.
Right. Yes, I will say congratulations on getting the agency request bills passed. I know that's not easy. And I want to thank everyone for attending our meeting today. We, as I said, when we started out, we deeply appreciate the time and effort that the committee members are giving to this and that are invested in it, in attending the meetings and in helping out the board. Your engagement is crucial as we work together to try and lower healthcare costs. A reminder that the recording and summary of the meeting will be posted shortly on the HCA website, and our next meeting of this group will be on October 23rd from 2 to 4 p.m. And I look forward to seeing you all then, if not somewhere before. And since it's not till October, I guess have a good summer and hope you all get a vacation.
Thank you all.
Thanks,
Have a great
everyone.
day.
Have a good afternoon. Bye.